2nd. And so we are able to have CME credit for today's lecture. And so if you would like to claim credit, please be sure to text DBHi1 to the standard phone number, which is 215-274-0239. It's the same place as always. And you can see those disclosure statements right there. And so then we're going to have a Q&A session at the end of the presentation. For those of us here in the room, you can raise your hand, obviously. But for those online, we'll be monitoring the chat so that we can deliver those to Dr. Scheinker. But if you are online, please be sure to mute your microphones. And so I am privileged to introduce Dr. Scheinker today, who's going to present his work. And Dr. Scheinker has over 110 publications and conference proceedings, many of which are very high impact work, including his work with partners there at Stanford who are working on diabetes monitoring, which have been published in high profile venues like Nature Medicine and Nature Digital Medicine. He's not actually going to talk about those things today, but you can ask him about it later. And actually that work was identified by the Clinical Research Forum as one of the top 10 clinical research achievements of this year. Okay, we nailed it. Okay, and also he's a co-investigator on an AI moonshot grant from Hoffman Yee. Very exciting stuff. And so I'm really pleased to have him talk with us today.
Thank you. Thank you for kind introduction. I want to mention that even though there's time for questions at the end, I hope to say at least one or two new things. So if any questions in the room come up, maybe that's a perk of being here in person, please feel free to interrupt and ask for a clarification or anything else. I have time to talk to leave about 10-15 minutes at the end, so there should be plenty of time for questions throughout it. So I have appointments at the School of Medicine, at the Children's Hospital, and at the School of Engineering, which really facilitate this interdisciplinary work. And my research group is called SIRF. I advise Carter Healthcare, and Google has given us gifts for this work. So my motivation is this seminal work from 1999 that aviation offers lessons for a systems approach to safety. This was one of the first times that people quantified something on the order of 100,000 deaths per year in the US due to potentially preventable medical errors. And this report did an amazing job advocating that aviation offers valuable lessons. Aviation transitioned from incredibly high accident and mortality rates to this unparalleled stellar record of safety through systems approaches to safety. And then healthcare was argued, rather than relying on the nurse and physician to always perfectly, for example, make sure that surgery is performed on the correct site, instead of relying on a person to do that, go to a systems approach where the site of surgery is marked in advance, confirmed several times. And these efforts, when implemented, saw significant improvements in the reduction of safety events. And what I'll argue in this talk today is that aviation offers similarly valuable lessons for efficiency, which have seen much less uptake from hospitals and the medical community. For example, rather than relying on a nurse to potentially manage all of the specialties in the unit, all of the seasonality associated with staffing, and to do it efficiently in a way that meets patient needs, there could be a systems approach to building the technology and the decision-making to support that kind of longitudinal staffing. So right now, I know you all do amazing pediatric surgery here. We do amazing pediatric surgery at the Children's Hospital at Stanford. In particular, our cardiac surgical program is one of the ones we're most proud of. And this is still how scheduling still happens. We get referrals on a fax machine that It's a picture of the Bible, that if it was ever, the victim of a spilt latte, would estimate a year of pulmonary artery reconstruction scheduled procedures. And that magnet board is how we try to balance patient arrivals to the post-anesthesia care unit to prevent congestion and the PACU going on hold and backing up surgeries, where the magnets correspond to the procedures, the strip magnets, the little circular magnets, they correspond to the type of unit someone's going to go to after the procedure. Red is the cardiovascular ICU, yellow is the PACU. And the colors of the magnetic strips corresponding to the procedures were just because we bought a variety pack to do this. They don't actually mean that. But this is how we have humans try to optimize our complex surgical schedule to prevent congestion downstream.
We have a magnet board as well.
Yeah. And again, to the credit of the schedulers running this, this was a great way to do better than before and actually reduce some of these preventable. Nobody requests a PACU bed and then 10 people request a PACU bed in the same 10 minutes. In contrast, in aviation, there's more than 50-year history of a focus on exactly these types of scheduling and coordination problems being tackled with sophisticated mathematical optimization methods. So this is from an MIT doctoral dissertation in 1996 on the left, capturing how they think about this as a holistic problem. And in fact, one of my mentors at Stanford, Professor Margaret Brandeau, she's an incredibly well-respected, award-winning cost-effectiveness researcher, came to Stanford to get a PhD explicitly because she wanted to work for an airline afterwards. This culture of deploying and developing optimization in aviation is fully aligned with academic departments training that workforce. And on the right-hand side, you see this aviation scheduling. It's a commercial product used by Lufthansa and others, where you have these individual components that can be optimized, but also you have considerations of how optimizing them all together. Integrated optimization, where you look at all of the possible combinations at the same time, can provably help you achieve better results than sequential optimization, where you just optimize something in isolation, then move on to optimizing the next thing with the first one as a given and so on. And at the hospital, we're not even quite at sequential optimization. We're kind of at like ad hoc improvement, and then ad hoc improvement a little bit later, and so on. So it's not stunning then to see these kind of differences. In red, you see aviation cumulative annual labor productivity growth. So aviation, I ended at 2019 with these Bureau of Labor Statistics data before COVID kind of made the chart jump around a little bit. But you have just seen well over 200% cumulative labor productivity growth, whereas hospital productivity growth has been essentially flat over this time. And it's not surprising then when you look at cumulative average annual costs, the cost of hospital care, and there are many ways to measure this. And essentially every way of measuring this is going to tell you the same thing. It's been growing incredibly quickly. And aviation, these are all in real inflation adjusted dollars. Those costs have actually gone down despite fuel, the number one cost driver, having gone up. And it's because the same runways, the same airports, the same crews, year after year are able to serve more passengers, fly more routes without increasing that capital cost. In fact, if you look at the ratio of capital costs to labor costs in aviation, they've stayed about flat, whereas in healthcare, the labor costs have increased their share. Okay, so that's kind of, I'll stop with the high level with this one last slide, and then I'll get into hospital segments. So improving efficiency with operations, research, and informatics. Almost everything people have to deal with has, to some extent, uncertainty associated with it ahead of time, complex constraints for how it must be dealt with, and then unexpected events that happen after you build and deploy something that what you built and deployed couldn't predict. So, for example, the uncertainty could be the durations in a hospital, the duration of a procedure, the length of stay. In aviation, maybe the duration of a particular flight, customer preferences, no-shows. So I'm assuming most people have heard of supervised learning to predict something like the duration of a procedure. For complex constraints like equipment, facilities, staffing with specialties, breaks, and union rules, those actually both apply identically to aviation and hospital. They didn't have to. Have people heard of mathematical optimization, something like integer programming? Okay, so this is much less common in healthcare, but the bread and butter of most operations for not just aviation, for example, Amazon. People like think about AI and Amazon, but AI is a tiny sliver of the value that Amazon generates internally. And mathematical optimization and integer programming represents the vast majority of how they do things efficiently and quickly and cheaply and well. And then unexpected events, storms, demand surges, no-shows, and last-minute cancellations. So the way I differentiate between these things is the uncertainty that's inherent in what's done can to some extent be reduced with machine learning. You know, some characteristics of a patient, you can give an estimate ahead of time of their surgical procedure duration or their post-operative ICU length of stay. Similarly, you can try to predict how many people are going to want to travel on Thanksgiving. Mathematical optimization is something that you have to do a ton of work to put in all of the constraints and rules of your systems, like OR nurses need a 30-minute break within the first 4 hours of their shift, and you have to staff enough nurses to cover that break to make sure the specialty services like neurosurgery are going to have somebody available for them even when the neurosurgery nurse goes on break. And then the simulation is when you build a replica of your system, a discrete event simulation, because the first two methods invariably, to some extent, require simplification. You know, when you're doing machine learning, it's personalized, but you're just making predictions on some features. And mathematical optimization, again, you're reducing your system to a set of rules, but the discrete event simulation is you've built something, then you can simulate everything that happened in your hospital or airline for a year, and then test the performance of your model when deployed. So your machine learning, for example, your predictions, you should have some expected accuracy rates and some, expected levels of really missing by quite a bit because there's a surgery that took 3 hours as long as usual. And that performance should, if you did it well, still match up with the performance you expect to see in the next year. What the simulation does is layer that on top of everything that happens. Like on some days you had 6 cancellations, or on some days you had a couple of procedures where your ML was really off. So combining these idiosyncratic real world things and how maybe 3 happen on one day and then none happen for a week, that's what you need simulation for, to really evaluate what the performance of these models could be in reality. So any questions or great. Please.
I guess when we're talking about like a simulation, like how would you like perform like a simulation?
Well,
on like a machine learning? Would you just observe those kind of outliers, or?
Yeah. So for example, we build a model for surgical scheduling, and we'll train it on all of 2024 through November. I guess the end of 2023 and then we'll build a simulation of everything that happens in our hospital in 2025. And then we run this new scheduling algorithm and schedule surgeries using this new thing from the training data in 2024. And then we evaluate it on 2025. But not only is it evaluated because we know how long the procedure took, it's evaluated via the simulation because in this, on this day in January, 4 different kids all had the flu and had the cases canceled, for example. And then both in aviation and hospitals, This is built on a foundation of you have technology that's both old and new. We actually have way more new cutting edge technology in hospitals than aviation. I mean, like onboard Wi-Fi and movies are great, but that's nothing like the transformational robotics, genomics, and other types of clinical technology that are constantly being deployed in hospitals. And there's the old technology. People heard about the Southwest holiday scheduling disaster. They kept putting off their crew scheduling system, which does optimize crew scheduling until there's one storm too many, and then the system crashes and they strand thousands of people for days, and it's just this huge disaster. So that was a legacy technology that they had been putting off updating. Obviously, incredibly complex regulations and safety requirements, and then non-customer counterparties. We deal with insurers, aviation, they have to deal with airports. Those are usually local monopolies that they have to figure out how they're going to contract with. So I'll talk about a few motivating examples. So we want to optimize surgical scheduling. The uncertainty includes things like procedure duration, their post-op length of stay, and the post-op bed demand. The complex constraints include OR and surgeon schedules, their specialty-specific operating rooms. The PACU beds, the ICU beds, the acute care beds, which aren't dedicated necessarily. So they're not only serving those electively scheduled surgical patients, they have lots of other patients using those beds. So you don't know exactly which beds are going to be available to you. And then there are unexpected events, last-minute cancellations, unexpected admissions, so on. A second example is to balance service to unit assignments. In any hospital, you have specialized units, of course, like a cardiology, ICU, and a cardiology acute care unit. But then you also have lots of services that share units where they don't have the volume for their own unit. So maybe, orthopedics and ENT are on one unit. But how to assign all of those shared units to all of those services to minimize the occurrence of, the orthopedics unit is full, we're going to have to send this ortho post-op patient to the oncology unit, or vice versa, where they're not going to have that same specialized nursing care. You want to reduce those off-service days. So that's a reassignment you can do once a year or once every few years. As different services grow volumes at different rates, they may no longer be aligned with the capacities of the units they're assigned to share. And obviously, volume fluctuations, respiratory season severity, those are uncertain, but you can try to predict them to some extent. Then there are complex constraints, maybe nurse specialties and unit capacities, and there are unexpected events, for example, COVID or other events that really disrupt the volumes of the services that you expected to have volumes similar to what they used to be. And then finally, want to improve daily patient flow decisions. We'll often have a request for a bed come in. We adjudicate it with a very manual process, and we say, I'm sorry, we have to turn this patient away. We just don't have the beds. And then at the end of the day, we have 3 empty beds on the unit that patient would have gone to. So I'll talk about some of these examples of the surgical scheduling. And so even though the diabetes work has had some very nice publications like Nature Medicine, Nature Digital Medicine recently, I'd say probably half of those 110 papers that GPT counted are about optimization, surgical scheduling, and these kinds of much more bread and butter hospital operations things. So one of the things we found is that uncoordinated elective scheduling leads to congestion. So a patient came in at the end of June wanting surgery over the summer when they wouldn't be in school, and the surgical scheduler chose this day on which there were already 6 admissions scheduled to the pediatric intensive care unit, even though there were these other days where the surgeon is available, where there were far fewer admissions scheduled to the same unit. So for example, if they had it on this day, there were only 3 admissions, or on this day, there was only 1 admission. And in reality, this is what happened. On that day of surgery, you had 7 elective admissions, 8 admissions the day before, which is very disruptive to 24-bed ICU. And the week before, and then the week after, there were far fewer admissions. So that would have been much better candidate days. So we built this as kind of our first digital twin just of the surgical service environment, where we built a simulation of surgical scheduling and post-op bed use, where we kind of carefully keep track of when does the patient show up to the clinic. At the time they come to the clinic and the scheduling decision has to be made. When is the surgeon available? What do we know about the already scheduled admissions into the same post-op unit they're going to go to? And then we can run this simulation. And one of the things that this allows us to do is we can design and then compare algorithms. So this kind of gives the details in pseudocode, but basically when a patient comes in and you know what kind of surgery they need, they've picked the surgeon, you know the post-op unit, and you know their window when they want to have it. There are many algorithms that you could potentially use to schedule that day of surgery. And the idea is that it's going to be really hard to implement in the EMR or in the processes we have something sophisticated, something that, you know, requires running and solving an integer program. So what we wanted to do was compare how would the most sophisticated algorithms benefit the system versus simpler algorithms that we could actually implement in Epic, ideally. And so what this does is it gives this systematic approach to comparison. Here's a visual representation of the same idea. You've got a patient coming in on June 30th, you know their service, their surgeon, you use machine learning to predict their procedure duration. So you know the patient's available in July. We don't actually have that perfectly in the data. We try to infer it based on the timing of the original clinic visit and the surgery classification. We know which surgeon they want, and these are the days when the surgeon has sufficient hours available. So Dr. Rinsky's already booked up on July 16th, but in theory, he has enough time on these other days. And then we know the post-op PICU surgical admits scheduled for those days already. So given that information, you can try to choose which day you want to schedule this surgery for to minimize this congestion to the PICU. Now, I mean, one naive thing you can do is just pick the day that right now has the fewest admissions scheduled and offer it to that patient. But then the question is, are you leaving a lot of potential benefits on the table by doing something simple as opposed to doing some kind of fancy dynamic program that, for example, tries to consider the conditional probabilities of subsequent arrivals needing that day or other things? And so that's what the simulation allows us to do. What's the trade-off between something that's going to be either difficult or frankly infeasible to implement versus something that we think we can implement, which is still by no means a given. And so we compared lots of these algorithms, and we actually found that this very simple greedy algorithm performs almost as well as far more sophisticated algorithms. So we built a simple model in Tableau, which we then had as a very realistic tool to work with our surgical schedulers. This is the other nice thing about a simple model. It doesn't cost time or money to prototype it and to show it to people in a tool they're familiar with. So we came to actually our surgical schedulers and said, here's the idea. Try to get the patient to agree to the greenest day. Try not to offer them the red days. And this was still like a year-long process where our CMO had to get personally involved and the surgeon chief and others, and we made changes at the same time. But they approved this approach to scheduling, and we actually were able to deploy it in Epic because like the color-coded calendar functionality is something that Epic supports. And so this has been up and running since 2020. Of course, the start of COVID isn't the best time to evaluate the efficacy of an elective scheduling algorithm. So I've been remiss. I should just go back and analyze the last 5 years of data. But basically, we did some very early analyses, and what we saw, and again, probably like us, you have seasonality patterns. So we, when we looked at August through December 2019, before it was implemented 2020, And then January through March 2020-21, this was implemented in July of 2020. So we saw, for example, there were 8 days with 5 or more admissions in 2019, and there were 0 days with 5 or more admissions in 2020. There was a reduction in case volumes. This was like the first winter after COVID hit, of course. And then in the winter months, there were 0 days with 5+ admissions in both instances, so not a particularly. But again, that's like a very low volume respiratory season. So more rigorous analyses of these are coming, but it is intuitive. It does coordinate our scheduling, and the data, though not compelling that there's a measurable benefit, we're certainly not cause for pessimism. So now I want to talk about another example of this kind of project to improve surgical scheduling that combines these methodologies, a different outcome. So we have cardiovascular surgical cancellations, unfortunately, far too often. And basically, if somebody's been waiting 8-12 months for pulmonary artery reconstruction, all these incredibly complex 18+ hour long procedures, and you have to cancel on the day of, that's devastating to the family, to the care team, to everybody. And we found that, unsurprisingly, cancellations were far more likely when the cardiovascular intensive care unit has more elective surgical patients in it. It seems like a little bit of a weird metric, but we don't control when the heart comes in and the kid needs a heart transplant. We don't control when a kid needs to go on ECMO and is going to stay in the CVICU for a long time. We do control the elective surgical patients. So we wanted to check if just those patient volumes that we do control are sufficiently high that they correlate strongly with the risk of cancellation. And that is the case. When there are a lot more patients in the CVICU there for elective surgery, 11, 12, or 13 or more, then all else being equal, it's much more likely that the unit is full and that a procedure might be canceled for lack of an available bed. And, we have all of these kind of typical things in the context that I'm sure you're familiar with: paper-based scheduling, informal policies and negotiations, and really heterogeneous patient ICU length of stays. Okay, so again, we're going to predict their post-op length of stay with machine learning, then we're going to schedule with optimization, and then we're going to evaluate with discrete event simulation. So the first thing we do is try to get an upper bound of efficiency. Suppose we could perfectly predict patient length of stay. Could we actually make things better? Maybe there's just too much variability with all of the non-elective surgery, or maybe the system is just congested. There's more demand than capacity. So maybe the whole exercise is pointless if things can't be improved. So the first thing we did was, okay, we're going to tell the model exactly how long everyone's going to stay. How well can it do scheduling surgery? And it drastically improves. So daily ICU occupancy by elective patients, essentially you can reduce the daily occupancy by elective patients to always be 9 or fewer patients. And you can do it without delaying patients' wait time to surgery. I mean, one thing optimizations will do if you don't prevent them is, oh, sure, I'll decongest your system for you. I'll just schedule everybody 5 years from now. So we're also tracking not only occupancy, but how long it takes to schedule the procedures. Are we delaying the care? So if you can predict length of stay, you can get massive benefits. So this isn't a pointless exercise. Unfortunately, length of stay is unpredictable and it changes over time. So our training data, 4 years from 2014 to 2018, this is the percent of elective patients and the number of bed days in the CVICU. And then it drastically changed. The same in our test data, 2018 to 2020. Basically, we had hired another surgeon. We had started doing a lot more complex cases. And inevitably, as patient care and populations change, the length of stay and other aspects of their care change. So what we actually saw is that robust stochastic optimization with various congestion versus wait time trade-offs does not outperform the paper-based system. The length of stay is so unpredictable. We have this incredibly rich data set from both the EMR and also the clinical registries, which are these, gold standard nurse hand adjudicated answers to important patient characteristics. And we were not predicting length of stay. And it's not only because we're dumb, it's because two patients with very similar rich feature sets at the time of scheduling, just empirically, may stay 2 weeks versus 8 weeks. Like the data at the time of scheduling just does not differentiate post-op length of stay. And then the model needs to be told, how much do you weigh trying to reduce congestion versus how much do you weigh trying to not delay patient care? And so the results are, in the cases where you can reduce congestion, you're going to make patients wait a lot longer. And in the cases where you're not going to make patients wait longer, you can't reduce congestion. This is a surprising finding that the variation is so high, we can meaningfully outperform the paper-based system. Then we actually worked, and this was like a much more sophisticated conservative stochastic optimization. I mean, this would get into like computationally difficult runtimes. And there we saw modest improvements. So if we tune the balance between trying to reduce congestion and reduce wait times just right, then it looks like, so each of these dots represents a full simulation of 2 years of using this system, then we can maybe reduce congestion without increasing wait times. And that can go from, this is 1 year of simulation to this year to potentially kind of modest benefits. So based on, we can't do it with a simple heuristic and even very sophisticated technology that we're not super confident we can implement in practice with the hospital tech stack, offers modest benefits, we decided not to pursue this project. And ironically, some of the problems, this was published in a good academic healthcare journal, and the other paper that's led to work that's been implemented and useful for 5 years is still a preprint. So those both kind of fundamentally leveraged simulation on top of other methods, and I'll talk about our ongoing project, this digital twin. So this is representation, an abstract of how we try to reproduce everything that's happening in the hospital. And I was telling Ian about this before. We had built simpler models to represent smaller parts of the hospital, and they work. But when we tried to model everything in the institution, not only specific surgical scheduling, we weren't able to reproduce reality. And it's because there's an expression, if you want to understand something, explain it to a computer. It's because the way hospitals run are so complex and still human-centered. So you may have to encode a 25-step process just to get somebody into surgery, because there has to be a post-op bed requested. Somebody hopefully gets around to looking at that post-op bed request, confirms that it's available. Then somebody actually has to schedule the surgery and request the bed. That needs confirmation and so on. So when you try to digitally reproduce every communication that actually takes place, you see the complexity that we're dealing with manually in the hospital. And if at any stage someone just doesn't, refresh their screen or check in or doesn't get that phone call frantically asking them to do something, there are delays. But reproducing that level of complexity is necessary to have a simulation that reproduces reality in a way that's useful. I tell my students all the time, all models are wrong. Some models are useful. We needed to reproduce our hospital's complexity to make a model that's useful. And what we have to do is have all of these different things that kind of happen to us. People arrive to the hospital, transfer request comes in, somebody comes into a clinic to schedule a surgery. Then we have to have all of these handlers. Like event comes in, it's sent to somebody to handle it. And we wanted to build this in a modular way so that if my colleagues in engineering build a better way to forecast patient arrivals to surgical clinics in the next year, then we can just plug that in. If somebody else can improve mathematically how we represent something, we want to be able to plug that in without having to rework a lot of the underlying code of the model. So which is these have to be handled very explicitly and separately. And so in the current state on the left, our multi-year planning is done with Excel sheets for linear projections. How much is each service going to grow in volume? There's the linear projection on data, and there's also what the service line person or the surgical division chief predicts because they're optimistic and they want more funding.
Yeah.
And then there's this daily bed management where it's this large meeting people from all over the hospital are pulled in despite being very busy. And they have an Excel sheet where they have the current census of these different groupings of units and their projected census. So with the digital twin, we want to facilitate multi-year planning where we model various scenarios of capacity and demand using a model that's hopefully more useful than an Excel model. And then what we'd really like to do is facilitate daily bed management with the exact same interface they have. We want to meet them where they are. They're used to this Excel sheet. It's simple, intuitive, but we want the projected census to be the result of the output of a model that runs in the background and accumulates all relevant data, as opposed to the result of a person running simulations. Right now, we have people who are thinking, okay, I've got these requests for beds in PCU 400. Well, if we accept 2 of these patients and then these elective surgical patients come, basically people are running simulations in their head to try to generate these forecasts, to try to make decisions. And computers are better at running simulations than people. So one of the first use cases, and this is the interface of the model, unfortunately, is it's still basically driven by emails and meetings. So how many beds should we, oh, I'm sorry, it says reading. It should say, how many beds should we reallocate from maternity to acute care? We're having, this summer volume surge in acute care surgical bed demand, like we always do. We seem to have some capacity in maternity. Okay, they email us or they ask us, and we have fantastic partners on the left and hospital leadership and performance improvements. And on the right, it's my colleagues and the fantastic graduate research students who do this work. So then we have to ask them lots of questions. And this is one of the things we do really well is understand the context. Okay, which unit are you thinking about it? Over what time period? Within what limits? What's the outcome you want to measure to figure out what the right answer should be? And there's this subsequent back and forth. Then we run the model and then we say, okay, it looks like repurposing between 5 to 7 beds is optimal. And on the left axis in blue, you have the off-service patient rate in acute care. You don't have enough beds, your patients go on service. The more beds you reallocate as you go from left to right on the x-axis, the lower that off-service patient rate gets. On the other hand, in red, you have the doubled up hours. When are we going to have to put 2 moms together in a room in maternity? Because we've given away some rooms. And that increases as you go to the right. And you see that between 5 and 6 repurposed beds, you seem to have the biggest benefit for acute care off-service patients and the relatively limited impact on maternity. So this seems to be a sweet spot. So this is the kind of actionable recommendation we can give by simulating different scenarios after we get clarity on exactly what to measure now. So another example is optimizing service to unit assignments. I mentioned this briefly. We want to minimize off-service patient days and minimize days under 90% utilization. It's kind of empty. There are constraints. Hem-onc and stem cells should be on the same unit. Neurology and neurosurgery should be on the same unit, et cetera. So this is an integer program. There are, potentially billions of combinations of services to units. And there's some nice things we can do. We can use 10 a.m. instead of midnight census, which is much closer to peak census than the middle of the night. We can project for the next year, and then we can say like, hey, maybe we want to co-locate all our general pediatrics patients instead of having them spread out through the entire hospital. Can we do that and still do this? So this is a very classic use of integer programming, and we actually get a proposed set of assignments and the corresponding metrics. What's the average occupancy going to be if you put these teams together? What are the days under 90% and days over 100%, meaning you're going to have to send patients off service? And then our stakeholders said, well, look, it looks like you put all of the surgical patients on PCU 400. Can you put urology there as well, which used in yellow, which used to be on PCU 300, and then rerun the simulation of how this looks, even though it's not optimal, maybe it's close enough to optimal that it's worth the benefit of co-locating all the surgical specialties. Of course, not the cardiac surgical, which is elsewhere. And so, actually these, I changed the numbers around just to, preserve our hospital's data, but these are very realistic numbers, and this with slightly different numbers is actually being put into effect for next year, and we're working on doing this for the Stanford Medicine Adult Hospital as well. It's kind of a no-brainer not to let services remain on units where they are for just historical reasons, when a better solution to this jigsaw puzzle might just benefit everybody. So this is this kind of exciting thing that we're working on now. Lucille, it's a proposed interface for this simulation. Instead of having to go back and forth with my team and me to ask a question that we use the simulation to run, we'd like a large language model to just be a self-service tool. And what we have to do is set up the large language model to work with our simulation. An LLM cannot simulate a year of a hospital running. That's just totally outside the scope of what it could currently even try to do. But an LLM can use a piece of well-structured software. Even that's really hard. So we're trying to start with a simpler use case. So how many beds should we allocate from maternity to acute care? So we'd like Lucille to ask all of these clarifying questions, because Lucille will go back asking for clarification until she knows how to translate the parameters that she needs into this config file. Then that file will be passed to SWIM, the simulation, which is still going to remain untouched. It's validated. We know how well it works. And then it's going to give the results to Lucille, which can then interpret them for the hospital stakeholders. This is still ambitious and really difficult. The config file for this detailed simulation and even structuring it so even most common use cases can fit into that format is still a work in progress. But we've actually have a working demo of doing this for service to unit assignments. So this is just an overview of this agentic system architecture. And we use Chainlit and just some other basic out-of-the-box tools. And we applied it to the service to unit optimization problem because it's so easy to de-identify that. It's just a day, a service, and a number of patients. So we can do it on the non-secure infrastructure. We don't have to do the additional full layer posting it all internally. And so these are actually screenshots of this working version of Lucille, where it says, welcome to Hospital Bed Allocation Optimizer. Here are my available data. I can optimize with 10 a.m. or midnight census data. Here's a list of the things I can do. And the basic thing that the user might want, we just make it a button. Optimize the unit service allocation. So she will let you know the assumptions she's making about the capacities and say which medical services do you want to include? Do you want to have any constraints? And here are some constraints that I know about ahead of time. And do you want me to include weekdays only or all 7 days or weekends only? We focus on weekdays because that's usually when occupancy is high enough that it matters. So you just type in this response, include all those services, weekdays only, and put Gen Peds and PCU 360. We're sick of them having spread all over the hospital. We want to see how well can we do if we add this constraint. And so Lucille actually runs the model because it's a relatively small set of parameters that are passed to the integer program. The integer program that we built and validated remains untouched and gives this output that Lucille then gives to the user along with some of these summary statistics. So, yes, that's our proof of concept. And in general, we're going to try to build more use cases, and we're trying to build the infrastructure so that if anybody builds a tool that can be useful for the hospital, then they can drop their tool into a version of Lucille just for that tool, and then expose that interface to hospital stakeholders. So they have a natural language interface, which combines the flexibility of LLMs with a validated code that works. So I'll just wrap up with the challenges and barriers to improving like aviation that I think about for hospitals, and I think about as kind of a broader trajectory of my career. And we've talked a lot about operational optimization at the top, and this LLM-based interface that I want to try to use to democratize access to these tools that are only available through graduate students. Scheduling. So airlines have 90% digital self-service and 10% call center for the complex things when problems arise. Hospitals are about the opposite. 10%, if that, digital self-service for like very routine clinic procedures. Some places they still have 0%, and 90% call center. The challenge is that you are limited to any kind of scheduling optimization being a 12-month process of training your schedulers and having new workflows and change management. Whereas if you have more digital scheduling, then the improvements to the digital scheduling that are algorithmic can be implemented immediately. Billing and payments. So credit card fees about 3%. They take care of all of, you want to buy a ticket, that's what the whole thing costs. So just on the hospital side, billing and payments consume 15 to 20% of revenue. Appeals, denials, delays, reworks, mailing boxes of paper to Edna's warehouse. Automated billing and prior authorization requests, CMS is moving in that direction. And we've done some work to show that this is possible. Basically, LLMs are a fantastic tool to try to standardize contracts. Right now, every contract every hospital has with every health plan, there's something like 327,000 health plan contracts in the country, one for every 1,000 people. What we've shown in some recent research is you can actually use LLMs to help read these contracts, convert the exact same content that they've agreed to into a digital format, which could, in theory, facilitate standardized digital contracts, which can then facilitate more standardized and automated billing, prior auth, and other things. And these are other areas I've published on. I'm happy to talk about when people are interested. And all of these will then kind of form a foundation for this better optimization of how we provide care in the hospital. So standardized digital contracts actually incentivize efficiency and allow for automated billing. Then this will facilitate self-service scheduling because you can include the rules. Are you allowed to schedule this or not? Will be paid for or not? Which all can help optimize operations. So that's it. I'm happy to take questions at the time we have. Thank you.
So we've got one online from Steve, who asks, what is the secret to adoption and buy-in for operations research at Stanford? How did it start?
That's a great question. Started with a lot of like elbow grease and shaking hands and just kind of building this from scratch. But I'd say the most important part was physically going into the hospital and talking to people about what their problems and challenges are, which seems obvious when I say it, but so many research projects start with a researcher saying, I think I can do this cool thing. Let me look for people at the hospital that are willing to say this thing is cool, and then I'm going to use their problem as a toy model for the abstract project I'm working on. And that's the default, and it does not lend well to translation. If instead you go into the hospital, tell me the problem that bothers you most that you think is solvable, and you get that answer, and then you build them the simplest, dumbest, most basic thing that's a little more useful than what they have. That's just useful enough that they're willing to use it. It can be an Excel sheet. One of our biggest successes was an Excel-based karma tracker for which surgical service should be bumped when an unexpected procedure arrives, that considers how often have you been bumped and how long ago. And then if you get them something they can use, even though it's not research grade or publishable, you can use that to then build more sophisticated things already in the foundation of being in their environment. That's my one suggestion.
Just in terms of jargon, so can you distinguish digital twin from a discrete event simulation and kind of what the terminology there, what is really the difference there?
Yeah, so I think digital twin is a broader term. People use it also to mean digital twins of people.
Yeah, that's what I more think about it. It's clinical
Exactly,
trials, and we're simulating people and,
Yeah.
yeah.
So a digital twin of a hospital is typically everything you can represent about patient throughput through the hospital based on data from the EMR and other modalities, and also non-EMR data like nurse scheduling, environmental services, and so on. So every discrete event, somebody showed up to a clinic, they scheduled a procedure, they left their room and the room had to be cleaned. Just represents all of that. And the discrete event simulation is the specific technical approach to simulating it. There are other simulation approaches.
It's kind of interesting with the whole airline thing. And I will get to the actual question, but you can gamify your airline departure if you're leaving from somewhere. They'll offer you incentive. They'll say like, hey, your flight's canceled. We'll give you $1,000. I don't have any kids. I don't have anywhere else to be. I often gamify that. It works a lot, actually. Same thing with jury duty. I wonder, like, just you can reschedule it like the day before Thanksgiving, and it's just canceled. Yeah, give too many secrets away. But I wonder, like, not on a hospital system, but like a customer facing, like, not that I have any surgeries coming up, but if somebody did, like, I guess for best outcomes or like least likely ways to have your surgery or procedure or something canceled, I wonder if that kind of information is out there for the general public.
I mean, there's definitely, I think, some things that have made it into the public, like never schedule your surgery right when the new residents start. I mean, that's kind of made it out there. But in general, I think if we reach the point of efficient digital scheduling to the point where people could gamify it, we'd be so much better off than we are now. Where people are like, I hope I don't show up for my 15-minute tonsillectomy and wait for 3 hours, or show up after an 8 months wait list for heart surgery and have it canceled the day of.
Yeah.
So this kind of gamification at the margins, it'd be great if we got anywhere near those efficiency margins.
Dr. Hills, did you have your hand raised?
I did. Thanks for the talk. This is very, very interesting, and definitely a lot of light bulbs were going off for me during your presentation. I kind of sit at the overlap of informatics and hematology, and one of the slides that you had where you were trying to simulate kind of bed occupancy and where patients should be, kind of bread and butter for us in hematology, especially in a children's hospital, is individuals with sickle cell disease. And quite often they end up on a different service, or we're really on a different floor than the primary service that's taking care of them. And that actually translates to different care management because some of the nurses on those floors aren't actually trained to do some of the care that we provide to them, and that ends up sometimes increasing length of stay, we've noticed. So I guess my question is, for someone to try to be able to look at optimizing a simulation, do you feel like in your experience that picking a specific case around a disease population versus, all elective surgeries, for example, has less constraints, or you feel like it's actually more difficult because you're not including factors that could like potentiate, the issue? I'm just kind of wondering in your experience, like if I were to try to do something like that, you know, would that seem to be more feasible than maybe attacking all of elective surgery, for example?
Yes, so certainly if you need less buy-in from fewer departments and divisions, it's just politically easier and more manageable. It's also really important, at least this was in our hospital, it's really important that your institution doesn't have assumptions came from consultants that came in, looked at your hemonc unit and said, oh, it's always full. Oh, your volume is flat, it's not growing, because they didn't count hemonc patients that were off service to generate their projections of future hemonc volume. But then, yes, I mean, we've done projects, for example, to optimize infusion scheduling, and especially when you have people coming in for infusions on a regularly scheduled basis, that gives you a longer horizon to optimize how you schedule them compared to people that just need to come in for one-off procedures. It's definitely politically easier the fewer departments it touches, but you still have to be careful to make sure that when you do intersect with other divisions and departments that, you carefully bring them in to partner with you on it.
Yeah, thank you.